watching KBC Channel 1, and tonight I am joined by the UN Resident Coordinator, Siddharth Chatterjee, and we are going to be talking about the strides Kenya has made as far as the health sector is concerned, and of course, the input that the United Nations has had over the years in this sector, as well as other issues that may arise. Thank you very much for joining us today. I must say that you have a huge wealth of experience. How has that been ever since, for you personally, ever since you took office here?
So, Edward, I came to Kenya in 2014, and that was the time where I saw that the First Lady of Kenya had started her Beyond Zero program. The government of Kenya had unleashed what was called the Free Maternal Health Policy. But we wanted to get a better understanding of where the critical mass of the high maternal mortality really lay, because Kenya was also classified amongst those 10 most dangerous countries in the world for a woman to give birth. And therefore, the First Lady started this very important clarion call called "No Woman Should Die Giving Life." And I just thought that was a great clarion call which got the entire UN system united behind her in wanting to make sure that that really happened, that no woman should die giving life. What we found in an analysis that we did county by county, that 15 counties contributed to 98% of the maternal deaths out of the 47. And therefore what we did was, under the stewardship of the Ministry of Health and the First Lady's office, we convened the 15 county governors that came together and signed a public communique on the 27th of August 2014 to address the issue of maternal mortality, to address the issue of adolescent health, to address the issue of improved access to reproductive health and rights and proper services, but also to look at issues such as traditional harmful practices, such as female genital mutilation and child marriage, which contribute to the high maternal mortality rates. From there, we did an analysis of these 15 counties, and we found that from these 15, there were 6 counties that contributed to 50% of the deaths. Mandera, Wajir, Marsabit, Lamu, Isiolo, and Migori were 6 outliers which did not even fit into the overall frame of the country, and these were the 6 counties that were essentially pulling Kenya down. So if you look at the Millennium Development Goals, which Kenya admitted it did not achieve, to less than 170 deaths per 100,000 live births. But in 2014, we were looking at close to 488 deaths per 100,000 live births. And in a county like Mandera, for example, the deaths were as high as 3,795 per 100,000 live births. Now, what does that mean? Let's take Wartime Sierra Leone. It had 2,000 deaths per 100,000 live births. And here we are talking in a period of relative normalcy. And that is where we got together with the Ministry of Health, the UN system came together, United Nations Population Fund, UNICEF, WHO, all came together and said, look, let's go and make a difference to where the need is the highest. Mm-hmm. So these were difficult counties, not easy to access. There were issues of insecurity and all that. But let me tell you, in a year and a half to 2 years, they have leapfrogged the kind of results that we were expecting. In fact, this even got acknowledged by the World Economic Forum, which invited Kenya to Kigali to actually showcase what was it that it was doing differently in terms of making such a rapid improvement. In fact, the improvement that we've seen in these 6 counties that I've mentioned, yes, under normal circumstance would take 5 to 10 years.
All right. In terms of policy, how has the Kenyan government ensured that as much as we have given these responsibilities to the counties, but we have to also assist as well?
You know, I think devolution is the best thing that has happened to this country. And we've seen the fruits of devolution actually at the primary healthcare level, at the level 4 hospitals that we've worked in. Let me give you a good example of this. There was a twin outbreak of Chikungunya and Cholera, which took place late last year.
Yes.
We went there to Mandera County with the Minister of Health. That county was not just providing services to the people of its own county, but there were Somalis and Ethiopians also accessing those services, which probably a few years ago was unthinkable, simply because those health systems were very weak or, very, very fragile. So what devolution has done is empowered the governors to actually take responsibility. And I have to say that in many counties, it's working very well. It's work in progress. Keep in mind, perhaps Kenya has seen the fastest pace of devolution that anywhere else in the world has seen. And I really believe that The governors have taken responsibilities, the members of parliament have taken responsibility, the faith leaders, the religious leaders have, in a sense, taken responsibility. In fact, in 2015, we managed to bring the religious leaders together to also focus on the high maternal mortality, to improve the primary healthcare systems, to improve upon the harmful traditional practices that were taking place in this country. So I really believe that devolution is the way to go for Kenya. That will open up the opportunity, because what we need in Kenya is the convergence of two very important things: good education, high quality education, and the relevant education and skills, combined with good primary health care. If we've got this right, over the next 5 years, Kenya will start to leapfrog, because what is happening is the median age of this country is 18. It's the youngest country. This is the youngest continent in the world.
Yes.
The median age is about 19. Over 70% of Kenya's population is less than 30. What we have to make sure is they have good education and skills, and they have the right health. So health includes good nutrition. There's a large amount of stunting in many parts of Kenya because of malnourishment. So these are young people who in their first 1,000 days have not received the right micronutrient inputs. As a result, they will grow up into young people but are unemployable because their cognitive skills are not developed. So the logic of where recently we were in Davos and then in Durban for the World Economic Forum, the Minister of Health has spoken, and we in the UN system are completely united behind him in saying Kenya can actually leapfrog primary health care and reach every one of those 46 million Kenyans in the next 5 years. And you know why? Because we have the technology for it. Today we have to look at the intersection of technology, human capital,
yes,
and to learn lessons in other countries that have moved forward. What we've managed to see in these 6 counties have shown us that Kenya can do this throughout the country. And what's interesting is that Kenya itself can generate enough of revenue,
yes,
in terms of let's call it a 100 shilling or a $1 Robin Hood tax,
yes,
that it could actually bring considerable amount of resources to the table. But it can't do it alone. The government can't do it alone. Civil society can't do it alone. Faith-based organizations can't do it alone. We're also bringing in the private sector. And what is interesting is that the private sector is also getting increasingly interested in looking at this, because they are looking at also future markets. The population of Kenya is 46 million now. By 2030, the population will be 65 million. By 2050, it will be 85 million. To me, the primary healthcare space is a massive opportunity where we can see the convergence of public-private partnerships, expanding the healthcare space, bringing in more insurance, ensuring that every Kenyan is insured so that we don't lose those 1 million Kenyans every year to deep poverty simply because of a catastrophic health shock.
All right. We have slightly above 5% of the GDP going to the health sector. Do you feel that for that needed improvement to be achieved, probably the government should consider adding a little bit more to the health sector?
Look, finally, these are public policy decisions. It needs the decisions of economists. It needs the political decision. All those things need to come together. But let's take Singapore. Singapore actually invests about 5% of its GDP on public health.
Yes.
If you look at the health of a Singaporean, they are probably far ahead of the curve than many other countries in the world. So the Abuja Declaration, the African countries committed to 15%. You know, when I look at the cost analysis, benefit analysis of this, it's fantastic if a country can get to 15%. But let's be realistic, it's difficult.
Yeah.
So that is why in Kenya, we are actually opening up an innovative landscape where we are bringing in other partners into this. So I mentioned this Robin Hood tax to you. If we were to invest 5% of GDP, which is far higher than my own country, India, invests 1.2% of its GDP on the public health care space. So Kenya is actually doing pretty well.
Yes.
But what we need to do is bring in other partners. Finally, there are 3 Ps, my friend, that will matter here, Edward.
All right.
First is political will. Now we are seeing an abundance of political will. This political will should remain on focus to make sure that in the next 5 years, every Kenyan can enjoy access to quality primary health care. That is preventative health. Every child is immunized. The action on non-communicable diseases and good behavior, healthy lifestyles, you know, ensuring that the reproductive, maternal and child, adolescent health is at the center of the primary healthcare space, because this is what will contribute to to human development. And now these are not impossible to do. It's not impossible for a governor to ensure that 100% of his children and women are fully immunized. In fact, we could have an incentive. Why not have a 10 million Kenyan shilling award at the end of the year for a governor that actually ensures 100% immunization? Look at the benefit that the country will get. Bottom line, if we can, that landscape can improve rapidly. We don't have to go beyond 5%. It is how we can mobilize other partners, the private sector, foreign direct investment, getting in, multilateral investment, all those things, and ring fencing what I termed as this a Robin Hood tax kind of thing that the government can bring in, which can make sure that everybody is insured. But what is interesting is that the healthcare space will open up employment opportunities. Keep in mind, every year, 1 million Kenyans plus are born. Every year, 1 million Kenyans in the age group of 15 to 24 join the labor force. Every year, they have access to about 80,000 formal jobs and the rest into the informal sector. So what we have to do, to me, it's clear. We will never have the number of doctors that we need for this. Africa is short of 50% of doctors. So we will have to lose technology, telemedicine, video streaming equipment, etc. What we want to open up is the landscape for an army of community health volunteers.
We have the private sector also chipping in and helping the government tackle issues that are arising in terms of health. But we also have runaway cost of medication. You buy a drug at 10 shillings in one health facility, and when you go to the next one, it is 50 shillings, and we move to the next one, it is 100 shillings. How do we find a way of solving that, because it does not work for the benefit of a common Kenyan who cannot afford?
Edward, those are not impossible to do. I was talking about the 3 Ps, and I talked about political will. The second P is right policy. So the government's job should be ensuring the right policies are in place, the right norms and standards, right monitoring. Those should be the responsibility of the government, right? And the third is partnerships. These partnerships are crucial. So once we start to make sure that the entire ecosystem of public-private partnerships come into play, the insurance company coming into play, the government providing the norm standards and regulatory mechanisms to make sure that is there, you will find this work seamlessly. It works everywhere else. It works in Asian countries like Singapore and South Korea and Malaysia and Indonesia. How come? So it's just not it's not this thing. It's just a matter of getting it right. I'm quite confident, and I say this without equivocation, that if we were to make sure that these 3 Ps converge together of partnerships, policy, and political will, next 5 years, Kenya will achieve universal health coverage. This is the goal as set out also by Dr. Tedros, from Ethiopia, who's recently become the Director General of the United Nations World Health Organization. I think we've got the right, should I say, the inflection point where we are at to make that transformation. This is that moment to do it, because if we miss that boat, my worry is that we will start to get old before we get rich. And you can only get rich when you have the right educations and skill and you have the right health.
All right. We have diseases like cancer. The war against malaria is almost being won, but we've seen cases where Kenyans have to travel abroad to access treatment for cancer. How do we make it affordable and available for everyone who is in need of such kind of treatment?
Good question. Good question. And I think, see, the issue is we have 2 types of disease burdens. The communicable disease, which are preventable through vaccines, and in Kenya they've just introduced the Malaria Vaccine, which hopefully would be able to cover everybody. Let's see what those results are like. But malaria still kills a large number of children in this country. We have to be mindful of that. So the fight against malaria must go on. We should achieve the Singapore gold standard of a country which actually comes from the swamps, is malaria free. And it's about good hygiene, good healthy practices, not allowing good sanitation. Those are things that have to accompany the health system to improve it. So you can have a lot of preventative stuff, which includes non-communicable diseases, which means improving upon nutrition, not allowing malnutrition, because malnutrition can be both sides. Malnutrition, one that leads to obesity with excess consumption of sugar and getting diabetes and all that. And the other malnutrition is where the child has no form of proper nourishment, where the micronutrients, such as simple things like iodine, are not available. So we will have to find the right balance. And so non-communicable diseases will have to be looked at with the same lens as communicable diseases.
The government and the county governments, they've already signed the CBA with the doctors, but now the bone of contention is with the nurses. What this does, if at all it is taking the country back, how far behind is this taking the country, and how do you make everyone happy?
A doctor studies hard to get to where they are, so do the nurses. But we'll have to look at an opportunity of task shifting too. That is why the government will have to look at methods, methodologies where they can ensure that their doctors and their nurses are properly, paid and they are also kind of able to advance. But that is why I'm talking about task shifting. Edward, regardless of the numbers of doctors and nurses we have, we will never be able to keep pace with the way the population is growing. Keep in mind, Kenya was 7 million in 1956, the same as Sweden, population-wise. Today, Kenya is 46 million, Sweden is 10 million. 2030, Kenya is, 65 million, and by 2050, Kenya is 85 million. The population of Africa will be over 2.3 billion by 2050. So that pace will never be kept. What we will now have to look at is simpler, easier solutions where tech-savvy people start to come and play. As you start having this army of community health volunteers, you will find equity comes in. Good health is equal to equal to happiness, and that's what we need to invest in. I think this government and any government should be cognizant of the fact that that a healthy population only contributes to the health of an economy, and that there is a clear interlinkage between that. And that is why when I said that we have to invest in education and skills and in good primary health care is the route to which we can take this country off. And this country is at that point for takeoff, to go into a middle to first world country by virtue of the leaps it's already making.
There was funding that was it was revised down by the USAID. What do such kind of actions do to a country that is trying to take off in terms of health?
You just can't be dependent on a few countries for your aid for this thing. That paradigm has changed, And I just think we have to look at that new paradigm, the new paradigm of real partnerships, of, let's say, American health companies being able to come and make an investment here, like the GEs and like Pfizer and like Merck, and looking at what a return of investment will look like. That is how you will be able to create sustainability. That is how you'll be able to ensure that these companies, it's not about corporate social responsibility and a private company comes here and goes off. So the government has to take responsibility for the health and well-being and education of its citizens. Now it's about what kind of partnerships it's able to forge to make that happen. I believe Kenya's Vision 2030 is a brilliantly articulated document. I think if we were to stick to the preamble and to the nuances and to the spirit of letter and word in that document, we would be able to achieve this. In my view, where I'm sitting, having been here for 3 years, Kenya is at that inflection point where we can achieve primary health care in the next 5 years and become an example for other African countries to emulate.
The war on corruption, as it is right now, what impact is it going to have on the Kenya's health sector in the long term?
I don't think there is any country in the world which has been immune to corruption. And let me say this, without any equivocation. The most important thing is, how do you get over it? Let me put it in a very simple way. Let's say that, you're going in your car and you're stopped by a policeman and you've committed a mistake. Okay. Now what happens is, instead of paying that fine by cash, what if you were to M-Pesa that fine, which goes straight into a finance facility? I really believe that today there is enough of technology available to us to bypass some of those systems of corruption. Because, don't forget, I think it's a scourge which is universal and not limited to countries. What we have to find is the right mechanisms, first of all, to prevent the corruptions. Number two, to make legal systems so robust that the sledgehammer of justice that follows corruption should be visible and exemplary. And number three is to take advantage of the technology that is available at our disposal to minimize those chances of corruption. And it's all here in this country.
Would you rather have a country where you have really huge health facilities, or you have the big hospitals, but then again you have small health facilities that are efficient, that there are cases that they can deal with, even the surgical, and make it easier for everyone to easily access them.
Absolutely. So you'll have to look at the ecosystem. That is why when we are talking about this, we've established a platform under the leadership of the Kenyan government, which I co-chair, incidentally, with the Minister of Health. It's called the Sustainable Development Goal Number 3 platform. It's about partnerships to look at, from the primary to the tertiary healthcare, how do we make sure that people have access to quality healthcare. Now, let's take a pastoralist community in Wajir County. They may not be able to access a large size facility. Why don't we have a mobile facility instead? Why spend money on putting up facilities there when a mobile facility can access them? But certainly primary healthcare facilities within easy reachable distance. And if it is not, then connect it through mobile systems. But the important thing is, we are going county by county in this platform to look at what is a basic minimum package of services that are needed. Services in the northeastern counties would be very different from the services in Nyanza, for example, where the prevalence of a burden of HIV is much higher. So what would be the right balance, and then how do we deal with it county by county? So what we intend to do is to come up with a business plan of what a minimum package of primary healthcare services looks like at that county, invest in it, unlock the financing mechanisms that are available both locally and globally, and to look at that opportunity of taking it forward. Oh. But as it was said, that no man is an island, every man is a piece of the continent. I think in the primary healthcare space, we can actually demonstrate it.
Any last words from the UN?
From the UN side, I think Kenya is at a very interesting place. I think what we must see is Kenya ensure that the 4 E's of education and skills, of empowerment, making sure that women and girls are able to achieve their full human potential so that they can contribute productively to the economy, that there is a Marshall Plan of employment, that there is employment available to each one of those 1 million Kenyans to join the workforce, and finally there's equity. Equity is important. The moment societies, communities, others start feeling that they are unequal from the others, then do we have problems of instability. I think we are at a place where we can address all 4 E's.